colorectal cancer treatment's not just about eliminating a disease. It's about preserving life quality and empowering patients through every phase. So I think nurses are really at the forefront that we can do that in the oncology nursing space. So from early detection to survivorship, the journey is deeply personal. Precision medicine, compassionate care, and informed decision-making are reshaping outcomes. Treatment's just not about protocols, it's about people.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Kris Mathey, GI Medical Oncology Nurse Practitioner at the James Cancer Hospital of The Ohio State University Wexner Medical Center, about colorectal cancer treatment. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Welcome back. Thanks so much for joining us again today, Kris.
Thanks for having me.
So before, we spoke to you on a previous episode about colorectal cancer screening, and you're back today to talk about another part of the cancer care continuum, which is treatment for colorectal cancer. So before talking about treatment considerations, let's kind of pause and briefly just discuss the disease itself. Can you give us an overview of some of the common types of colorectal cancer?
Colorectal cancer has several different types, but there is one that dominates the landscape, and that is adenocarcinoma. So I think most of us have heard that. It's fairly common, and it accounts for about 95% of all colorectal cancers and begins in the glandular cells lining the colon or rectum and often develops from polyps, in particular adenomatous polyps. This is why we talked about in the previous podcast on screening why it's really important for this early polyp detection and removal. There are some subtypes for adenocarcinoma, and these are mucinous as well as signet ring cell. So mucinous adenocarcinomas contain the high amount of mucus, about 60%, and these may be more aggressive. And then signet ring cell adenocarcinomas are typically rare and more difficult to treat. There are some less common colorectal cancer types, and these are carcinoid tumors, which arise from neuroendocrine cells and tend to grow slowly, as well as our GISTs, which is our gastrointestinal stromal tumors. These are a type of sarcoma, and they arise from the connective tissue of the GI tract. Furthermore, looking at the more very rare and extremely rare, we have colorectal lymphomas, which are a form of non-Hodgkin lymphomas that start in the colon, and then our leiomyosarcomas, which are, again, extremely rare, and those develop in the smooth muscle of the colon or rectum. But as I mentioned, the majority of these are adenocarcinomas. This is, with all these possibilities, why biopsy is important and helps guide treatment.
Absolutely. Well, thanks for reviewing all of those. You know, it makes me think, and I think this all the time, but especially when you're online, you're in certain patient support forums and things where I think there's a misconception that colon cancer is colon cancer. Everyone has the same type. And we know that's not true as oncology nurses. And that's basically true for every site-specific disease, is that you can call it this colorectal cancer, but within that, it's all can be very different depending on what subtype you have. So I really appreciate you highlighting the most predominant one, but also some of those rarer ones that still do show up and that we see in our patients.
Oh, yeah. And we'll talk about it in a little while, but we really find that no one colon cancer type is the same. And while adenocarcinoma for one patient is not necessarily adenocarcinoma in the next patient. So I tell my patients, you look at the statistics for any type of cancer, but you're not a statistic, you're a human being. So we have to remember to treat that. And then also, as I mentioned, with that biopsy, tissue is really the issue. So getting that tissue so we could look at those molecular markers to really cater treatment to that.
So let's break down a little bit. What are the percentage of cases diagnosed at which stage? So how do we see that distribution?
The percentages reflect the importance of really early detection. Again, screening. You're going to hear me say that over and over because we know that these localized cancers have significantly better survival rates than those diagnosed at a distant stage. So our localized, and those are about 39% of cases, and that's the cancer that's only in the colon or the rectum. 35% is our regional stages, which that's where it's spread to nearby lymph nodes. And then you have your distant metastatic disease, which is your stage 4 cancers. And those are about 22%.
Moving on, as you mentioned, as part of the diagnostic workup and also some of the preliminary testing to really guide treatment decisions, it really is so important to get this information so that we are making the right choices and sharing that information with our patients. So can you review some of the more common either diagnostic testing and procedures or biomarker testing that we should really be looking for to make sure those are incorporated as part of the care plan and decision making?
Nurses play a key role in interpreting the medical records and supporting our patients in their treatment planning and decisions. Diagnostic and biomarking testing has really exploded in the past 5 to 10 years. And for me, even as a GI medical oncology nurse practitioner, can be difficult sometimes to keep up. But that's what this education is for. But there are some key biomarkers that can help determine prognosis as well as guide our targeted therapies and predict treatment response. So one of the biomarkers that we'll most commonly hear about is KRAS or NRAS mutations. This indicates a tumor genetics, and these mutations suggest a resistance to our EGFR inhibitors such as cetuximab. BRAF mutation or V600E is a more aggressive tumor subtype, and those may respond to our BRAF targeted therapy. So when we talk about this, when we're looking at what type of treatment, you're really looking at these biomarkers and saying, oh, they have a BRAF mutation, so we really want to get something that targets that mutation. And then our MSI high or MMR deficient, microsatellite instability or mismatch repair deficiency, that really predicts an immunotherapy response and may indicate Lynch syndrome, which is a huge genetic component that takes a whole nother level of counseling and genetic testing with our patients as well. Another major biomarker that we see is the CEA tumor marker, and I'm going to totally butcher this, so this is why I usually just tell my patients CEA, but it's the carcinoembryonic antigen. And this is really a tumor marker that's in the blood. It's used to monitor treatment risk or recurrence. Now, with a huge asterisk next to that. So I think, most of us as nurses are pretty type A, myself included. If I was a patient, I would be wanting my CEA checked constantly. I would have it plotted on an Excel spreadsheet, and I would really be looking at that like crazy. But keep in mind that not every colon cancer expresses that CEA. And while it is something to look at for that treatment response, it's not 100% guarantee. So that's where we really use our imaging studies, such as our CAT scans. So it gives us a good idea of how things are doing, but it's not 100% and shouldn't really be the only thing we use to guide treatment response. Really, our imaging with our CT scan should be helping with that. So that's one thing, kind of pet peeve that I have as well. Our circulating tumor DNA, that's the tumor DNA in the blood. This is something that's really, we're getting more and more information on. I'm seeing more trials on the circulating DNA as well. And this can help with detecting residual disease or recurrence as well. So after surgery, testing for that residual disease, because we do know we'll look at the pathology after surgery. We'll be able to say, hey, clear margins, but our technology and our eyes can only take us so far. So that circulating DNA is something really coming on the forefront that's able to tell us, is there residual disease circulating in the blood? There's some other tests that nurses may see. That's the tissue biopsy report. So these often include the molecular testing results. Liquid biopsy you'll hear, and that's those blood-based tests that use that circulating DNA or tumor markers such as the CEA. Genomic panels, you may see these labeled as either next generation or NGS sequencing or comprehensive genomic profiling, similar to how our medications have to have 17 different names just to confuse us. A lot of these panels and tests will have different names too. So these are just some highlights when you're looking through a chart of knowing what they are. Immunohistochemistry or IHC. This is used to detect protein expression. So you'll hear this for HER2, MMR, and proteins. And then our FISH or PCR testing is used to detect specific mutations or gene amplifications. So nurses really should know the stage of cancer, where some biomarkers are more relevant in metastatic disease, and then the timing of the test. So as I mentioned, the CEA, it is super helpful to get a CEA prior to surgery. Also, so you know what they started with and to get that information for when you're looking in the chart. And then also you'll check that after surgery to see how the patient responds. Now, not all patients mark for CEA as well. So just keep in mind, if they didn't mark for it prior to surgery, they may not mark for it after surgery. But if they did mark for it, say it was super elevated prior to surgery, they have surgery, hopefully all the cancer is removed, it comes down to below 5 or undetectable, that's a great response and something for us to really be happy about. And then these biomarkers often can help determine eligibility, as I mentioned, not only for targeted therapies, but also clinical trials. So you'll see that coming on the forefront a lot more recently.
Thanks so much for overviewing all of those. I mean, it just highlights how complex that even a single patient's diagnosis can be, and how important it is to not only understand what each of these results can mean for the patient, but also how it influences what treatments they either are or are not eligible for. And then, of course, most importantly, being able to translate all of this information to the patient and their family and caregivers so that it is meaningful to them, so that they understand. I really appreciate your description of the CEA and how, I remember when that was sort of all we had.
Right.
We kind of only had that, and we sort of put a lot of eggs in that basket. And slowly over time, we've had to coach our patients of like, this is just a single tool that we can use to get sort of a very sort of distant idea of what might be going on, but we can't always rely on it completely. And I remember seeing it just maybe jump up a little bit, but the patient still feels great. And so it's like, well, we don't want to rush and do anything aggressive. If that's just a momentary blip. And so that one is a very tricky one, because I do, as you mentioned, patients really can focus in on that and really kind of overvalue it when we know in big picture, there's a lot of other things that we need to be watching and just be considering when we're talking about treatment or restarting treatment. So just a lot to consider, and for us as nurses to be familiar with, so that we can then, again, share that information with our patients. So moving on now, and once we have all that information, for some patients, before we have all that information, they have to have surgery first, or, we get the biopsies, we get some of this testing done as part of that surgery. So what are some situations where surgery is maybe the first or part of the treatment plan for colorectal cancer? And what types of surgeries are the most common that we see?
With our screening, I would love to catch cancer early, so that surgery is really the only thing we're going to do, as surgery is often the cornerstone of treatment for colorectal cancer, and particularly when the disease is localized or resectable. So early stage cancers are often curable with surgery alone. When cancers get a little bit more advanced, we will typically, our stage 3 cancer, sometimes our stage 2, pending on what that pathology shows, any high-risk features, we may have surgery followed by chemotherapy. And then your stage 4 cancer, surgery may be used more just to relieve symptoms or remove isolated metastases, such as in the liver and the lungs. Surgery can also be used for obstruction or perforation. So you may have a patient present with a tumor blocking and rupturing the bowel. So they're taken immediately for emergency surgery. And then if cancer is confined to a polyp, it may be removed during a colonoscopy. Now, I don't typically think about that as a surgery, but it is a removal of that tissue. So you may have some of your patients say, I had minor surgery to remove my cancer, and it was really that colonoscopy removing that polyp. Patients with FAP or Lynch syndrome may also undergo preventive surgery. So those patients that have our high-risk genetic conditions may undergo that. Now, there's several different types of colorectal surgery, and full disclaimer, I am a medical GI nurse practitioner, so surgery isn't my jam. I really appreciate my surgical colleagues, so I could talk to it, but I can't tell you exactly when we would do everything. But a polypectomy or a local excision, that removes our small tumors or polyps during that colonoscopy. And that's what's used for those stage 0 or early stage 1 cancers. A colectomy removes part or all of the colon. This may be open or laparoscopic. It can include a hemicolectomy, a segmental resection, or a total colectomy, so where you take out the entire part of the colon. A proctectomy removes part or all of the rectum. This may include a low anterior resection, also known as an LAR, so you'll see that abbreviation in the chart, or an abdominoperineal resection, which is an APR. So oftentimes I don't see those big words written out, and I'll just say patient under or see patient underwent an LAR or an APR resection. Colostomy or ileostomy, that diverts the stool to an external bag via stoma. Sometimes this is temporary or permanent depending on the type of surgery, and that's really a conversation to have with the surgeon before surgery, but also after surgery. A pelvic exoneration removes the rectum and nearby organs. This is really used for those advanced rectal cancers or recurrent rectal cancers. Cytoreductive surgery or HIPEC is actually really cool. It removes abdominal tumors. So if you have someone with peritoneal disease, essentially if you open their abdomen, it looks like sand sprinkled all over them. And so that cancer spread to the peritoneum. You could undergo cytoreductive HIPEC, and that removes the abdominal tumors. And then it actually applies heated chemo into that abdominal space as you have the patient kind of, sounds bad, but we say shake and bake. So on the surgical table, they rotate and that heated chemo spreads along all that peritoneal lining. So very cool technology and something that it could be an option for some of those patients. Robotic assisted surgery. This is that minimally invasive option, and this can be helpful to reduce recovery time as well as complications. And again, all of these different surgeries are dependent on not only the surgeon, but also the type of cancer and kind of location that it occurs in.
Thank you again for reviewing all those different options. And as with the other treatments that we'll talk about, it just really depends on the details of that individual patient's, presentation, where their tumor is located, how widespread it is. But it is important. I'm like you. I'm med-onc. I'm solid tumor. So I don't claim to be an expert in things that aren't that. But as a medical oncology nurse, you still have to understand, what are they coming to you with, or what are they going to receive after they get this chemo? So it is really important to understand, anatomically, what's going to be removed. What will they be left with? Does that mean they will have some sort of ostomy? And so all of those things are, while we might not be involved in the immediate post-op care for patients who receive surgery, we still need to understand kind of what that impact will leave for the patient when they still come back to our medical oncology service. So great information and great overview. Moving from surgery now into another modality that we'll see, radiation. What types of radiation therapy are used in the treatment for colorectal cancer, and when are they appropriate?
So Jamie, I think this really further provides evidence about the importance of multidisciplinary care as a component for colorectal treatment. So we already talked a little bit about surgery. We talked about biomarkers. I already said I'm medical oncology, so you're going to hear a little bit more about chemotherapy and immunotherapy, all that kind of stuff. But really, radiation is another tool in our tool belt that can be powerful in treating colorectal cancer, especially the rectal part of colorectal, where it's more commonly used than colon cancer. There's different types of radiation therapy as well. So you have our external beam radiation. This uses high energy rays from a machine to really target the tumor from outside the body. So I kind of think of it as a laser when I talk to my patients about it. This is most common. It's used before and after surgery or for symptom relief. Our intensity modulated radiation therapy, or IMRT, this is advanced external beam radiation that shapes the radiation beams to match the tumor. So it really minimizes the damage to nearby healthy tissue. If you all haven't seen how radiation works or looks at radiation planning, I really recommend Google radiation planning, because it's really neat how the radiation oncologists and therapists really can mold and shape. They'll look at a CT scan and really zero in on where they want that radiation kind of laser beam to focus. Stereotactic body radiation, or SBRT, delivers high doses to small, well-defined tumors. This is often used for metastasis, such as in the liver or the lung. Intraoperative radiation, or IORT, that's delivered directly to the tumor site during surgery. And this is used when complete tumor removal is uncertain. So we think we got it all, but hey, may need to try to get a little bit more and kind of help zap it a little bit. Brachytherapy is not something that we see too much in colorectal cancer. However, it can occasionally be used for rectal cancer, especially if there's a recurrence or inoperable cases. And this is where radioactive material is placed inside or near a tumor site. And then finally, radioembolization is where radioactive beads are injected into blood vessels that feed those liver tumors. So this is really radioembolization is for those colorectal cancers that have spread to the liver. So, okay, great. I told you about all these different types of radiation, but when is it appropriate? So for rectal cancer, before surgery, so neoadjuvant, we will use radiation to help shrink those tumors to improve surgical outcomes and preserve that rectal tone and sphincter function. And then after surgery for rectal cancer, we'll use it in the adjuvant setting to target residual cancer cells to further reduce that risk of recurrence. We may use radiation in place of surgery for rectal cancer. That may be for patients who aren't surgical candidates for a wide variety of reasons, or they may prefer non-surgical options. And then we may use radiation for recurrent disease and rectal cancer if the cancer returns in the pelvis. So colon cancer, again, as I mentioned before, radiation is less commonly used, but we may use it if the tumor is attached to other organs or the abdominal lining. Also, if the patient's having symptoms such as pain, bleeding, or obstruction, we could use radiation in the palliative setting for that. Or also if the patient has metastases such as bone, liver, or brain metastases, again, in the palliative approach for that. Further talking about palliative, we'll use radiation in advanced or metastatic disease to really ease those symptoms and ultimately improve quality of life, because that's what's important for our patients, not just that quantity of life, but ultimately quality. And in those advanced and metastatic disease patients, we'll use targeted radiation such as SBRT or radioembolization to treat those isolated mets. So radiation therapy is often combined with chemotherapy. You'll hear this called chemoradiation, and that's really to enhance the effectiveness, especially in rectal cancer. So that's another modality. You'll rarely see that we will just use radiation alone without chemotherapy. We'll use a little bit together to make everything work a little bit better.
Well, and along those lines, I know that everyone is different, but before we move on to systemic treatment, is there a typical kind of order that these different modalities are used if somebody needs to have them all? Is it typically kind of surgery followed by radiation, or where does chemo fit in there? Like, is there something standard, or is it really just dependent on what that patient's unique circumstances are?
It's dependent on the patient's unique circumstances as well as the stage of their cancer. So I tell my patients there's 3 different ways that we treat cancers. There's surgery, which is wham, bam, cancer's in one area. We just take it out. There you go. You're done. If cancer spread to just a little bit of an area, or it's too big that we need to shrink it in vessels or kind of get better outcomes, sometimes we'll do radiation to laser that to make things shrink prior to surgery. And we'll use chemotherapy with that as well. So prior to surgery to radiate to make things smaller. And then oftentimes we'll use chemotherapy after surgery. Again, if it's in the more widespread or metastatic setting, radiation tends to be more in that palliative approach. So surgery would be off the table, most likely for widespread metastatic. Sometimes for colorectal, if we have it in just the liver or the lung, we could still go in and do some resections of the mets there. But for the most part, radiation would be in the palliative, and chemotherapy or immunotherapies would be the treatment of choice for that systemic therapy option.
Thank you. All right, so now we'll move on to systemic therapies and treatments for colorectal cancer. And we'll take kind of each category of systemic treatment on its own, since there are so many. We can't just cover them all at once. So let's start out with immunotherapies. What immunotherapies are we commonly seeing used to treat colorectal cancer?
Immunotherapy is really transforming how we treat certain types of colorectal cancers and cancers in general. And this is used especially for tumors with specific genetic traits. So that's where I talked about earlier about getting that tissue, really getting a good biopsy and checking it for all of those molecular findings and uniqueness to each patient. We have our immune checkpoint inhibitors. Those help the immune system recognize and attack cancer cells by blocking proteins that suppress the immune response. Pembrolizumab or Keytruda, I feel like that's one that I see on TV all the time right now, but that targets our PD-1, and it's used for MSI high or MMR tumors, and that's approved for the first line or advanced settings. Nivolumab or Opdivo targets PD-1 as well. And that, again, is used for MSI high or MMR tumors. and that can be used alone or with ipilimumab. And with ipilimumab or Yervoy, that targets our CTLA4. Again, that's usually in combination with nivolumab for enhanced effect. There's more treatments on these immune checkpoint inhibitors that are coming out all the time. Dostarlimab or Jemperli targets our PD-1s as well. It's approved for MMR tumors, and that can also sometimes be used off-label. These are most effective in patients with microsatellite instability high or MSI high or mismatch repair deficient or dMMR tumors, which make up about 15% of our colorectal cancers. Ultimately, when's immunotherapy appropriate? We'll have our patients say, hey, I want immunotherapy. I see commercials on it that it works so well. But we have to make sure that these patients are good candidates for it. Also, that we're treating them adequately. We need to make sure that they have those biomarkers. So as I mentioned, the MSI high or MMR tumors or MSS stable tumors, they may benefit from newer combinations or clinical trials. Metastatic disease, immunotherapy may be used alone or with other treatments. And then in the neoadjuvant setting, some trials are really showing promising results using immunotherapy prior to surgery.
These are things that we didn't have 15 years ago. It's just amazing to realize how many new therapies that we have, how many new biomarkers we need to be checking for, how many new therapies they'll be eligible for, depending on what their biomarkers are. I'm always just overwhelmed when I hear even site-specific, we talk about just one single disease site and how nuanced and how complex it has become, but all for the betterment of the patient's outcomes because we are able to really focus on what their type of cancer needs for their treatment. So you brought up some great points, and I know we'll revisit some of those biomarkers when we talk about targeted therapies here just shortly.
I remember studying for my OCN and then my AOCNP, and I was so focused on those tumor markers. Okay, what's a PSA? What's a CEA? What's a CA19-9? Getting that all in my brain. And now all of a sudden it's looking at all these, okay, MSI high, PD-1, all these other elemental Ps. So much to keep track of. So yeah, it's awesome for our patients. It really is.
Well, let's pivot for some of the classic chemotherapies. What are some of those old but good drugs that we are still using to treat colorectal cancer?
Oh yeah, the oldies but goodies. So our classic chemotherapy does still remain the cornerstone in treating colorectal cancer. These are often used in combination with targeted therapies or immunotherapy. One of the ones that you guys will hear most commonly is 5-FU or 5-fluorouracil. Still seems to be the backbone of colorectal cancer treatment, no matter what you do. But this is an anti-metabolite. It's often paired with leucovorin to enhance effectiveness. Now, 5-FU is the IV form, and it's really kind of cool because it does have a pill form, which is capecitabine or Xeloda. So that's an oral prodrug of 5-FU. And while we say it's convenient that it's in a pill form, it does still have its unique side effects. The way I explain it to patients is 5-FU is one of the few drugs that we have that has kind of a sister or an identical twin in the pill form. So oftentimes you'll have patients be like, well, can't I just take a pill for this? Luckily, 5-FU, it's one that we can, but you do have to make sure the patients can swallow. There is some issues. Every patient's a little bit different, but the different risks for diarrhea, fatigue as well, they may react a little bit differently with that. So 5-FU, Xeloda. Then we have added to that is oxaliplatin, which is our platinum-based chemotherapy. This is commonly used in FOLFOX. So FOL, FOX is one of our main regimens. So the FOL is that 5-FU. The FOX or the OX is the oxaliplatin. The one thing we want to be really careful about this is neuropathy. So in your patients with oxaliplatin, it is platinum-based. So remembering back to our chemotherapies and those agents and those side effects, monitoring those patients for neuropathy. It is a unique drug, and I could talk about it for days. Obviously, I'm already talking about it a little bit, but it's funky because it causes this cold sensitivity. It's very hard to explain to patients that, and I tell them, once you experience it, you will know what I'm talking about. But it has this cumulative effect. So the more doses you get, the longer that cold sensitivity may last. And then it turns into a neuropathy, so the numbness and tingling. But really warning patients about, hey, be aware that you may be more sensitive to cold right after you get the oxaliplatin. And when I say sensitive to cold, I'll have patients that will drink cold beverages or stick their arm in the fridge and it'll feel like a shockwave going up their arm or like they're swallowing icicles. Now, I live in Ohio. It's really hot right now in the summer, but it's really cold in the winter. And so I tell my patients, make sure when you walk outside after your infusion to cover your mouth, because if you breathe in that cold air right after an infusion, oh my gosh, I can't breathe because those blood vessels are kind of spasming. It's that cold sensitivity. So I remind them, take a breath, but if you could talk, you could breathe. It's not a dangerous cold sensitivity. It's just an uncomfortable, some may say painful, but it is a weird side effect of the oxaliplatin. As a nurse, it's something that I almost sometimes say I'd like to experience just because it would help me explain that to patients a little bit more. Another key chemotherapy agent we have is irinotecan. This is often used in a FOLFIRI regimen, which is FOLFIRI. So you'll have, again, the FOL, which is your 5-FU or your fluorouracil, and then the IRI is the irinotecan. The notable side effect for this is diarrhea. So you'll really want to monitor your patients for diarrhea with the irinotecan. Irinotecan gets a bad rap as the nickname of I ran to the can for diarrhea. Another newer line in the past 10 years or so is Lonsurf, which is our trifluridine tipiracil. That's an oral combination chemotherapy. This is often used in later lines of treatment for metastatic disease. So as I mentioned, when I talked about FOLFOX, FOLFIRI, we use these in combination. Oftentimes we'll do FOLFOX. If that doesn't work, then we'll switch to FOLFIRI. But these drugs are typically administered in cycles, so tends to be about every 2 weeks, allowing time for the body to recover between treatments. And so it's really important for nurses and care teams to monitor those side effects closely. As I mentioned, that neuropathy from oxaliplatin, that neuropathy, that cold sensitivity may be worse right after treatment, but by the time they're due for their next treatment in 2 weeks, they may not have any issues. That's fine. But if they're seeing you in clinic, they're having problems buttoning their buttons or they're dropping things like, hey, I can't write anymore because I'm dropping my pen, or I'm walking with my coffee and all of a sudden that drops on the floor. That's an issue. And again, we talk about quality of life for these patients. So monitoring that neuropathy and making sure you let the prescribing providers know, and then monitoring that diarrhea for the irinotecan. Nurses are huge on monitoring the toxicity so that we know and we could communicate the need to adjust dosing and really support the patient's recovery.
And, one thing that you didn't mention, but is relevant to what you did say, is that the 5-FU, the fluorouracil, is a continuous infusion. And so these patients are taking this drug home with them in a pump. Similar to how you mentioned, if they're getting an oral agent, there's different assessments of just their ability to self-dose and all of the things that come with adherence for oral agents. Similar sort of practical questions and concerns have to be asked about a patient who is going to be expected to take this pump home, be able to troubleshoot it if there are issues. Sometimes, unfortunately, there's disconnection of the needle. And so those are other concerns that we really have to factor in when patients are being prescribed these treatments, because that is, again, putting a lot of responsibility on them and their caregivers. And there's that needed support and education of how to deal with that when they're at home.
And I failed to mention that. So thank you for bringing that up. That 5-FU every 2 weeks is an infusion over 46 hours. So patients will carry like a little, depending on where you're at in the manufacturer, but a little either satchel or like a fanny pack. So making sure that they're okay with that. Whereas I mentioned that the 5-FU is an infusion, the Xeloda is a pill. Well, that Xeloda dosing is twice a day, either twice a day for a week or twice a day for 2 weeks. So really both of those, you have to monitor the patient and see what works best for them, their family, and their lifestyle.
So moving on to relatively new kid on the block, antibody drug conjugates. And that's certainly a newer treatment that we're seeing on the oncology landscape. What types of antibody drug conjugates are we seeing used in colorectal cancer treatment?
This one, I'll be honest, I had to phone a friend, which my best friends are my clinical pharmacists. So if they are not in your back pocket, you do not know the name of your pharmacist in your area, I highly recommend, because they are fabulous people to help with this. I just wanted to make sure I wasn't missing anything. So I contacted my good friends, my clinical pharmacists. And as you mentioned, antibody drug conjugates are really an exciting frontier in all cancer treatments, as well as colorectal cancer treatments. This is used mainly for patients with advanced or treatment-resistant disease. And these therapies combine the targeted power of monoclonal antibodies with the cell-killing ability of potent chemotherapy agents. They're still on the horizon for the most part in colorectal cancer. However, there is only one approved antibody drug conjugate, or ADC, at this time, and that's trastuzumab deruxtecan, or Enhertu. That's approved for any solid tumor, such as colorectal cancer, with HER2 IHC3+. So again, looking back at that pathology and those markers, making sure that you have that HER2 mutation and that IHC.
You bring up an important new development that we're seeing, relatively new, is that their approvals are now almost disease agnostic. It's not about what type of cancer you have, it's what type of variant that you're finding in those biomarker testing. And so, as you said, for any solid tumor that has HER2, they might be eligible for this drug. And so that's just an important new twist on how we have to think about certain drugs, depending on what their FDA approval is for. But it sounds like, the horizon is still wide open for how we can use these types of drugs in colorectal cancer.
Absolutely.
So now let's round things out with targeted therapies. How are we seeing targeted therapies used in colorectal cancer treatment?
So targeted therapies have really reshaped how we treat colorectal cancer. By this really focuses on the specific molecular features of the patient's tumor versus that kind of one-size-fits-all approach that we previously used a decade ago. So this whole no one person's cancer is the same approach is what we're at now. With this, we can pinpoint cancer-driving proteins or genes, and instead of attacking all of those rapidly dividing cells like traditional chemo, these targeted drugs hone in on the molecules that fuel cancer growth. So they can really improve precision. So where treatments are tailored based on biomarkers such as KRAS, BRAF, HER2, and MSI status. And then they could also reduce that collateral damage. Because they're more selective, some of the side effects may be milder with chemotherapy. That being said, they still may have side effects. I think it's a misconception that, this targeted therapy doesn't have any side effects, because it does, but it may be different. And we're still learning a lot about that. So some common targets for colorectal cancer is our VEGF, or angiogenesis. These are used to treat blood vessel growth in tumors. These are ones you all know, such as bevacizumab, ramucirumab, or furquintinib. EGFR, those are for our RAS wild-type tumors, is cetuximab and panitumumab. For tumors with our BRAF mutation, those target BRAF V600E is our encorafenib plus an EGFR inhibitor. HER2, which way back in the day, we heard HER2 for breast cancer only, and now we're hearing this for so many. This is it's really exciting in the cancer world. But HER2 targets for colorectal cancer are trastuzumab, tucatinib, and lapatinib. We have our NTRK fusions, which are for rare gene fusions driving cancer, as well as these RET or RET mutations for RET-altered tumors. And more is coming on the horizon. These targeted therapies are really used in advanced or metastatic disease, as I mentioned, often combined with chemotherapy or immunotherapy, or after biomarker testing. So as I mentioned, these all are very specific to what they target. So that treatment really depends on genetic mutations or that protein overexpression. It's exciting because these targeted drugs may offer new options when we have our resistant cancers for standard treatment. So standard treatments failing, look, they have this mutation. Let's try this, and gives us some extra hope there. And then again, I've mentioned this a little bit earlier, but in clinical trials, we have many emerging therapies are being tested for broader use.
And now one question I had is, we obviously talked about the importance of upfront biomarker testing. In your practice, do you repeat testing for biomarkers? If and when they do progress or recur, is that something that you check again, or is it still just using sort of the original results?
No, we will recheck it. Not every single time with every single recurrence, but yes, we will recheck it. And it will be interesting that sometimes you do have those mutations. Cancer's smart. It's pesky. So yes, we will recheck.
So knowing all of these different treatment options, whether it's surgery, radiation, or the whole host of systemic therapies now we have, what should nurses consider when they're supporting their patients and guiding them through some of the shared decision-making that we want them to participate in as part of choosing their treatment options?
Nurses are pivotal in helping our patients make these informed treatment options. So we're the most trusted profession, but we're also the ones that are with those patients the most. So we act as educators, advocates, those communicators. So nurses can help with education and helping to clarify medical information and break down those complex diagnoses, procedures, and treatment options into an understandable standard language. Oftentimes we'll have, I love our physician colleagues, but they sometimes could talk in tongues where our patients are like, I have no idea what was just said to us. And the art of nursing is that we're able to break that down to a level that they can understand. Nurses can also aid in discussion in risks and benefits and help patients weigh pros and cons of each option, including side effects and long-term outcomes. One of the things about nurses and us treating our oncology patients is we have a lot of experience. So we could say, hey, yes, this book says these side effects, but I've seen these patients will have it more often than others. And again, like I said, not all of our patients react the same. So giving them that kind of communication and that empathetic discussion. Nurses can also facilitate in the shared decision-making, encouraging the patient to express their values, preferences, and concerns, as well as support the patient's autonomy, reinforcing that the patient is the final decision maker in their care, even if it differs from the clinical recommendations. So nurses are really pivotal in that treatment care team and for the trust of the patient. Along with that trust, nurses are helpful through that communication, as I already mentioned. So we create that safe space for patients to foster the open dialogue. Our patients in our infusion areas are often there for multiple hours. So there's lots of times that I know nurses are busy and we're running from one patient to another. But there are those moments where you're sitting hooking up drugs that patients may open up to you with that dialogue, and they want to be heard and respected. And we as nurses can help address the emotional and cultural factors that may influence their decision-making. And ultimately, nurses were the advocates for our patients and the coordination with the care team. We may be those ones aiding in the relaying the patient preferences to the physicians and specialists. You know, it may be awkward, but sometimes we may be the ones going, hey, Mr. So-and-so told me this. I just wanted you to be aware of. Or he's telling you he doesn't have any diarrhea, but he's getting up 5 times throughout the night to go to the bathroom. So those are just the little tidbits that we all can work together as a care team.
That's wonderful. Well, Kris, thank you so much for joining us again on the podcast and sharing all these wonderful details about treatment for colorectal cancer. As we get to the end of our episode, we like to always run through a series of quick fire questions just to help summarize some of our key points. And so to start that off, how do you think healthcare professionals can evaluate their hidden or their implicit bias about treating colorectal cancer?
So implicit bias is a crucial step in developing equitable colorectal cancer care. And I think one of the biggest steps that we could have is being aware that we all have a hidden or implicit bias. It's not something to be ashamed of. It's something to just be aware of. And that can require introspection as well as structural support. So just being aware of our own biases, reflect on the care that you provide. And sometimes it's helpful to just reflect on your patient interactions. Why did something make you feel uncomfortable? Or why did one patient go really well with you? So just kind of that self-reflection can help with that implicit bias. As I mentioned, just being aware, there's a lot of areas that are doing implicit bias training workshops and taking part in that, focusing on that cultural humility, trauma-informed care, and communication strategies. There's some training that you can engage in role playing and case-based learning. I know for me, I don't do well just reading about things, but if I could have case scenarios And sometimes reading about those simulations can really help uncover bias in clinical decision making and staying ultimately up to date on disparities research. For example, studies show that African American patients are more likely to be diagnosed at later stages and receive less aggressive treatment. So just knowing that that's something that can happen can make us more aware of that need for screening and to encourage that to happen. Some other patient-centered practices: ask, don't assume. Use structured questions to understand a patient's values, barriers, and preferences, and ultimately use that inclusive language. So avoid medical jargon and tailor communication to each patient's background and their individual characteristics. And then that also helps building trust. So acknowledging that and validate patients' concerns, especially in the underserved communities. So ultimately, bias isn't a character flaw. It's a cognitive shortcut. But in healthcare, these shortcuts can cost lives. This can lead us to have patients not trust us as much. So addressing these implicit bias isn't about blame. It's about accountability and growth by acknowledging and recognizing that there's this potential for implicit bias, and so that we could be aware and tackle this issue.
What are some common misconceptions about colorectal cancer treatment?
So there are a few myths going around about colorectal cancer treatment that can lead to confusion or even delayed care. One myth is only older men get colorectal cancer. As you heard me talk in my previous podcast on screening, unfortunately, this isn't necessarily true. Colorectal cancer affects both men and women, and our cases in the younger population is rising. So our screening guidelines have changed to age 45 because we are seeing it in the younger population. So encourage your friends, your family members. Colon cancer screening can save lives. It's not just a disease of the old. Another myth is I don't have symptoms, so I don't need treatment. Many patients don't present with symptoms early on, and these symptoms are more of a delayed diagnosis. And so treatment decisions are ultimately based on diagnosis and staging, not just on symptoms. Another myth is colonoscopy is the only screening and treatment tool. While it is vital, there are other options such as stool-based tests and imaging. Treatment may also include surgery, chemo, radiation, and targeted therapy, such as we talked about. So just really depending on when the patient's stage is. Colorectal cancer is always fatal. Fortunately, that is a total myth, because we know that when colorectal cancer is caught early, it's highly treatable. Over 90% of patients with localized disease survive at least 5 years, 90%. So again, that goes back to our screening. We catch these cancers early. They are not as fatal. Screening is not covered by insurance. Most health plans, including Medicare, at this time cover colorectal cancer screening. So that's something to help our patients and guide them with. And then a final myth is treatment's a one size fits all. And if you have taken anything from this podcast today, that is definitely not true.
Not true.
Yeah. Treatment's personalized, really based on those tumor genetics, stage, and the overall patient's health.
What is something about this topic that's not often discussed, but you wish people knew more about?
Oh gosh, I could get on my high horse once again about this. Colorectal cancer is increasingly affecting younger people, even children and teens. We're only really beginning to understand why. So while those numbers are low, the trend is alarming. So many of these younger patients don't have a family history or known risk factors. They're diagnosed at later stages because symptoms are often dismissed. So really thinking that changing our shift, that colorectal cancer is not a disease of the aging, but really it can affect all. So when you have a young female coming in with anemia, maybe let's do a full workup. Do we need to do colonoscopy on her, look at other causes for anemia other than just heavy menstrual cycle? It's also a reminder that cancer doesn't always follow the rules, and our systems need to be nimble to catch what's changing beneath the surface, because that cancer screening really can save lives. As I already mentioned in the previous podcast, cancer screening, 45 years old, no longer 50. So 45 is the new 50 for cancer screening. I wish it was 40, but we'll take 45 right now. And then the other thing is that there's a big transition to survivorship and shared care models going on with colorectal cancer right now. So once treatment ends, many patients feel kind of unsure who to follow up, what symptoms to watch for. or how to navigate some of those lingering side effects, such as radiation with diarrhea or that constant neuropathy if you're getting that from previous chemotherapy treatment. A recent study highlighted how shared care between the oncologist and general practitioner, so our PCPs, can improve survivorship outcomes. This shared care model replaces the routine oncology visits with PCP appointments supported by care plans and clinical guidelines. And it's especially effective with patients with that low risk recurrence with minimal ongoing treatment needs. So that really ongoing communication with our primary care providers as well as our oncology teams. And it's an important reminder that care doesn't end when treatment does, and that survivorship deserves just as much attention.
What additional training do oncology nurses need to stay current on this topic?
Oncology nurses benefit from a mix of continuing education, clinical updates, and hands-on tools. So there's many continuing education and certification organizations like the one we're proud to be a part of here today with the Oncology Nursing Society. So ONS does have a colorectal cancer library that has articles, podcasts, and biomarker databases to help nurses stay informed on emerging therapies, symptom management, and patient education. Furthermore, there's specialized programs such as the NCCN nursing program that provides updates on clinical guidelines, diagnostic strategies, and supportive care interventions for colorectal cancer patients. And then with precision medicine on the rise, understanding molecular biomarkers and genetic risk factors is really becoming essential. So many CE programs now include modules on interpreting test results and guiding patients through this genetic counseling. ONS has a fantastic biomarker database, which is a searchable tool that nurses can understand specific biomarkers, associated therapies, and testing considerations. And it's perfect as a quick clinical reference.
And finally, what are some additional resources for patients or other providers who want to learn more?
There's a wealth of resources out there for patients and providers to deepen their understanding of colorectal cancer. Many of these go beyond the basics, and there's a lot more than what I am just going to mention here. So for patients, there's the Colorectal Cancer Alliance or Blue Headquarters. This is a support hub that has some financial assistance as well as peer mentorship and survivorship tools. FIGHT CRC is another patient resource library available for patients, cancer care, and the Colorectal Cancer Resource and Action Network. For providers, the American Cancer Society has some great resources on colorectal cancer, as well as I already mentioned, the Oncology Nursing Society and our Colorectal Cancer Library.
Well, Kris, thank you again for all the wonderful information that you shared with us today on the podcast. Do you have any final comments to share with our listeners?
Yeah, thank you so much for having me. So just some final thoughts that often gets overlooked is colorectal cancer treatment's not just about eliminating a disease. It's about preserving life quality and empowering patients through every phase. So I think nurses are really at the forefront that we can do that in the oncology nursing space. So from early detection to survivorship, the journey is deeply personal, and advances like those shared care models where the oncologists and the primary care providers coordinate the follow-up are really gaining traction for their ability to support long-term wellness, especially for patients with low recurrence risk. With the rising cases in younger adults, awareness and proactive screening are more crucial and critical than ever. So whether you're an oncology nurse, a patient, a caregiver, my key takeaway is this: precision medicine, compassionate care, and informed decision-making are reshaping outcomes. Treatment's just not about protocols, it's about people.
Outstanding. Very well said. Well, thank you again, Kris.
Awesome. Thank you, guys. Have a great day.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.